All right, are we back?
Yes.
Okay, sorry, I don't have a, a clock, and then anyway, I exited out, then I had to try and get back into the Zoom. It's been a mess. Let's go on to chapter 6, which is the oral systemic disease connection. And this is where all of our commercials and education that the lay people are getting, it seems, to with heart disease and everything else. They're talking about the connection of one body system to the next. So we've got systemic risk factors. We talked about the local contributory risk factors. We also have systemic risk factors for periodontal disease. Are they the primary cause? No, because we know that is always going to be biofilm. Systemic, what's going on with the body? These are systemic conditions that may intensify the response to oral biofilms. So periodontal diseases only occurs when there's bacteria or biofilm and that susceptible host. And that susceptible host is, how is that body going to react to this inflammatory system that's going on? So we've got genetics as a factor, systemic contributing factor. There's a consistent association of periodontitis with certain genetically transmitted traits.
Misty?
Yes.
Your slides are not moving.
Oh, good grief. Can you see it now? Genetics?
Yes. Yes.
Oh, okay. I apologize. I've got like 20 chapter 6s up on my screen trying to figure out what's going on. All right, so genetics. Predisposing factors. One of them is interleukin 1. You need to know about this. Interleukin 1. It is a cytokine released from inflammatory cells. Interleukin 1. Okay, a cytokine. Remember what that is from last week? It's kind of how the cells communicate with each other. There's an association found between susceptibility to periodontitis and the presence of interleukin 1. 30% of the population are interleukin 1 genotypes. So 30% of the population have this interleukin 1, which means 30% of the population is going to be more susceptible to periodontal disease. Does that mean they're going to get it? No, it just means they're more susceptible. 30% for interleukin 1. There are congenital diseases with periodontal manifestations, and you're going to be looking into this more in depth with pathology with Mrs. Heberly. Hereditary gingival fibromatosis. That is not very common. Cyclic neutropenia, Down syndrome, Papillon-Lefèvre syndrome. Now, every board review talks about Papillon-Lefèvre syndrome. So when you get into this in pathology, just kind of perk up your ears. Same thing with Chediak-Higashi disease. Again, perk up your ears. Board reviews like to review this because occasionally there might be a board question. Papillon-Lefèvre and Chediak-Higashi are also, when you're giving blood, it's one of those screening questions that you have. Are you, okay, one of these people? Hypophosphatasia. Okay, again, you're going to be getting into all of these, but just kind of be familiar with some of these congenital manifestations. Stress plays a huge role. Chronic physical and psychological stress increase susceptibility to periodontal disease. Why? Because when you're under stress, the patient tends to pay less attention to the oral hygiene. Okay, for one. Then you've got an increase in production of the glucocorticosteroids, and that results in an immunosuppressive reaction. So if your neutrophils aren't being produced as readily or as actively because you're under stress and you've got poor oral hygiene combined with that, then stress is going to increase your likelihood of periodontal breakdown. And this is every dental hygiene student known to mankind. Diabetes is associated with the reduced ability to cope with the infections and impaired wound healing. This is classic diabetes. It results in hyperglycemia, too much sugar in the blood. And you've got your type 1 and your type 2. Type 1 is when your pancreas is no longer making insulin and you have to give yourself insulin on a daily basis in order to supplement what the body isn't doing. Type 2 is what we used to call adult onset, where the pancreas may be producing insulin, but not enough. So they need either oral or injectable medications to supplement. So each type of diabetes does require a medical consult through our clinic. Then when did you eat? Did you take your blood sugar this morning? What was it? But wound healing and delayed wound healing is one of those complications for all diabetes. If they're under control, not so much. But both types carry an increased risk for severe gingivitis and periodontitis. So periodontal disease can be more prevalent when the diabetes is not controlled. Hyperglycemia may suppress the host's immune response. Then you've got your impaired PMN production. They're chemotaxis, they're not talking to each other as effectively, and phagocytosis, they're not able to engulf and digest the pathogens as readily. Plus, you've got all of this wonderful sugar circulating in the bloodstream, which is feeding the bacteria anything it needs for energy. Hormones. You've got gingivitis and periodontitis can be more severe during periods of hormonal changes in both estrogen and progestin. So there's something called pregnancy gingivitis, and that's usually seen in the second and third trimesters. You have oral contraceptives, which mimic pregnancy in the body, and so they can have a similar oral manifestation. Puberty gingivitis for hormonal situations is more prevalent in females for some reason than males. And then it cycles back the other way. Menopause, osteoporosis, when the hormones are being depleted. Again, too much or too little can make the mouth over-exaggerate where there's bacteria. Osteoporosis. That's a result of estrogen depletion, which can lead to an increased bone loss. So because of that, men and women both may be prescribed some sort of bisphosphonate to combat the bone loss. So it kind of stops the osteoclastic activity, which means the old bone that naturally dies out isn't being absorbed. It's just sitting there. So patients that are on bisphosphonates have a propensity for some jaw necrosis, right? And again, it's the inhibition of those osteoclasts. They don't resorb the necrotic bone. It just stays there. So there's something called BONJ, okay? It's bisphosphonate osteonecrosis of the jaw. Its risk is lower in patients taking the oral bisphosphonates versus the IV bisphosphonates. So one of the things on the medical history is, have you taken any of this? Because what we want to know is if they have been on bisphosphonates, it's like a 10-year half-life. You're going to get into this with pharmacology with Mrs. Heberly. But if that patient is needing periodontal surgery, extractions, implant surgery, those type of things, they are at an increased risk of this osteonecrosis of the jaw. And sometimes it just spontaneously happens too. So we in clinic have a acknowledgement form, a release form that the patient needs to sign. This is a paper form. It's not on the computer, that they have been explained that there's a slight chance that this may happen and they are accepting the risk. Now we are doing scalings, root planings, root debridements. The risk is so minimal because we're not dealing with the bone itself. So bisphosphonates are also prescribed not only for osteoporosis, but for Paget's disease or bone metastases that are associated with multiple myeloma, breast cancers, prostate cancers. So bisphosphonates just aren't for osteoporosis. And like I said, there is a long half-life. It stays in your body for a long time. So the risk of this osteonecrosis increases after 3 years of oral bisphosphonate use. So what they're doing now in the medical field is they're keeping patients on it for a limited period of time. This is how we learn about what's going on with science. We put a patient on this wonderful medication, and then after 3 years, we start seeing stuff that's going on, and we scratch our heads and we come up with a new formulation. Hematological systems. We have blood dyscrasias that have been associated with extreme forms of periodontal disease. Right? Neutropenia is the main one. Then you've got your agranulocytosis, which you don't really hear about, but the neutropenia you do, and it's associated with an increased severity of periodontal disease as well as necrotic ulcerations. HIV/AIDS, their whole immune system is depressed, so they're more vulnerable for other diseases like necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis, as well as other periodontal diseases. And it's due to that impaired host response. Tobacco products. There's nothing good about tobacco products. It's a major risk factor for severe periodontal disease. The studies used to indicate for every 10 years somebody smoked, they could expect to lose 1 tooth. That's the math. But smoking suppresses the immune system response. So your PMNs don't function as well. So again, the PMNs are your first line of defense. Alcohol, poor oral hygiene, and malnutrition are associated with the increased use of alcohol. Now, we're not talking having a glass of wine at dinner every night. We're talking about more of the alcohol being a problem for the patient. It can affect the host defense, clotting mechanisms, as well as healing. Smoking does the same thing. And smoking and alcohol tend to go hand in hand for many of our patients. Dry mouth, xerostomia due to drugs. Almost anything the patient takes will cause dry mouth. Almost anything. Diuretics, psychotropics can cause dry mouth. Allergy medications can cause dry mouth. Salivary flow is decreased. That can interfere with plaque control because we're not washing our teeth with the saliva. Our tongue can't do the mechanical cleaning. Our food is getting drier, so it's not having the detersive action in the bolus before we swallow. Dry mouth, there's also that gingival overgrowth. This is constant in all your courses. This is constant. Also, the boards always ask you about gingival overgrowth. We used to call it gingival hyperplasia, but it's now gingival overgrowth because hyperplasia are certain cells. You have to take a sample to see what type of cells, but it's gingival enlargement that's in response to plaque accumulation. So you've got your anti-seizure phenytoin, you've got your calcium channel blockers, and you've got your cyclosporin. Know these medications that they cause gingival overgrowth. Sometimes the patient is prone to gingival overgrowth, even with meticulous oral hygiene. But the better the oral hygiene, the less side effects of the gingival overgrowth you'll get. Anti-seizure, calcium channel blockers, cyclosporin transplant. Obesity is now being linked to periodontal disease. Obesity is a form of malnutrition. That's all I'm saying about that. Periodontal disease as a risk factor, okay, for systemic conditions. The presence of periodontitis may be a risk factor for systemic diseases as well as pregnancy-related issues. Diabetes and periodontal diseases are bidirectional. The blood sugar control is so important. Periodontal disease may lead to higher levels of blood glucose in diabetics. So the more controlled the diabetics are, the better their periodontal status may be. And you're going to find when you're in a practice for a period of time, you'll have somebody coming in who's been stable. They're diabetic, they're stable, and their gum tissues look fine. And then all of a sudden they'll come in and they're a mess. They're a bleeding, inflamed mess. And that's when you have to have a talk. Okay. You said when we were reviewing your medical history that your A1C was such and such and your blood sugars are under control, but I can see from your mouth that something else is going on. So then you have to start delving into what's really going on with that patient. Cardiovascular disease. Okay, we're talking that oral systemic link. Periodontal diseases lead to an increased risk of coronary heart disease, atherosclerosis, and thromboembolisms. It's being linked with almost everything, including Alzheimer's. Adverse pregnancy outcomes. This was one of the first things that was discovered, I believe, at the University of Virginia. Women with periodontal diseases are more likely to deliver premature low birth weight babies. As you know, the gingival crevicular fluids increase with inflammation. And in that, you have your prostaglandin E2, prostaglandins, okay, create or stimulate uterine contraction. So an elevated prostaglandin E2 may stimulate labor contractions, leading to premature delivery. So periodontal disease could lead to premature low birth weight babies. Respiratory diseases. Increased risk, including pneumonia, bronchitis, emphysema. There's inadequate plaque control and oral hygiene that's going to increase the chance of developing respiratory diseases. That oral bacteria is a major factor for causing respiratory infection and may be aspirated in the lungs. And this is really big with our COVID patients that are being intubated. That mouth care, those nurses are in there doing mouth care for those intubated patients every 2 hours because this oral bacteria can be aspirated. And that is the end of this particular chapter. What questions do you have? Okay, fine. I'm going
Miss D, are
yeah,
you going to post chapter 6 on the Canvas for to do the quiz?
no, you just do the quiz blindly.
Because I'm not able to pull out chapter 6 PowerPoint on Canvas.
Doesn't matter. Just go ahead. No, I'm teasing you. What's the problem? Just do it. No, I will post it. I have to go to school after this though. And then, like I said, I've got a meeting tonight, so I won't be home until after 8. So I apologize if it's not going to happen, but I will try. Okay, I'm trying to figure out share screen. Can you see chapter 7?
Yes, but I think it's on your.
Yeah, okay. I just want, okay. So now can you see the next slide for gingivitis?
Yes.
Woohoo, okay. Okay. All right, let's just do roll on. I think we're going to go over today, but gingival diseases, we've had a lot of this already. Gingivitis, itis, as you know, is inflammation of. Gingivitis is an inflammatory lesion mediated by host microorganisms interactions, okay? So you've got your dental biofilm is the primary risk factor. Gingivitis, that biofilm remains limited to the gingival tissues. It does not affect the periodontal ligament, the cementum, or the alveolar bone. There is no attachment loss, and it is completely reversible. Gingivitis is a periodontal disease. Gingivitis is the only reversible stage of that periodontal disease. There is no apical migration of the junctional epithelium. That's another way of saying there's no attachment loss. There's no apical migration of the junctional epithelium with gingivitis. So gingivitis can be acute or chronic, localized or generalized. So now we're starting to use words that are coming into your perio assessment, all right? Acute, short duration. Gingivitis is usually chronic, long duration. Is it localized, limited to a small area, or generalized over a large area? And for perio and everything we're looking at, 30%. If it's 30% or less, it's considered localized. If it's 30% or more, it's generalized. Where is that 30%? That's that gray area. So we've had this histopathogenesis of gingivitis before. The initial stage, early stage, okay, established an advanced lesion. These lesions, 2 to 4 days, 4 to 7, 2 to 3 weeks, and then longer than that. So the initial lesion is 2 to 4 days. That's acute inflammation. It's when it first starts. We don't know if it's chronic yet. You've got a protective wall of those PMNs, your neutrophils. It's your body is trying to fight this ensuing infection. It's still at the subclinical level. Then you've got your early lesion, which is 4 to 7 days. That's acute inflammation. Your T cells, which you're going to get into pathology. The clinical signs of gingivitis are first seen. 60 to 70% of the collagen is lost. Okay, so early lesion. The initial lesion you don't see. The early lesion is just starting to show gingivitis. The established lesion is weeks old, 2 to 3 weeks old. That then turns into chronic gingivitis. And then you've got your advanced, which is an undetermined time. That turns into periodontitis, is the advanced lesion, is apical migration of the junctional epithelium. So you have gingivitis. Is there attachment loss or not? That's one reason why we need to see where the see radiographs, because you can have a gingival pocket, which your probe reading is 5 millimeters. You can even have 6 millimeters on your probe, and you're going, oh my gosh, they've got so much bone loss, but they don't have any bone loss. It's just inflammation of the gingiva, no loss of attachment. And this is where the pseudopockets come in, and this is where radiographs are so important. Where is that bone in relation to that CEJ? And what does that bone look like? A pseudopocket has no attachment loss. What's the host response to the gingival inflammation? You've got the initial response is vasodilation. Remember those hemidesmosomes and desmosomes, those gaps, they kind of stretch out to allow more fluid to come into the gingival with the gingival curvicular fluid. So you've got swelling, vasodilation that leads to an increased permeability and exchange of fluid, and the migration of neutrophils from the connective tissue. Okay, so that vasodilation is allowing neutrophils to go into the site of infection. That increased vascularity results in redness, swelling, and edema. So we've got our classification of periodontal diseases, and it's just changed. You have to know the 1999 classification, and you have to know the 2017 classification. So the 1999 was plaque-induced gingival diseases, okay? And they had a whole stream of plaque-induced gingival diseases. You have gingivitis associated with the endocrine system, hormones, puberty. Okay, now look at this, your Provotella intermedia, your P intermedia, this is a bug, is associated with puberty and pregnancy gingivitis. Diabetes associated gingivitis due to poor blood sugar control. All right, your pancreas, your endocrine system. Again, gingival diseases modified by systemic factors. That's the endocrine system. Pyogenic granuloma, pregnancy tumor. Bleeds like a son of a gun. It's a dormant tumor stimulated by pregnancy. The doctor will want to electrosurge or laser this off, and it usually comes back. It's due to a reaction of something. There's something in there that's rough. Blood dyscrasias, leukemia. These are things to think about when you have a very compliant patient. You've done everything that you can do to control their disease. They're doing an impeccable job, and you've ruled out everything. It's not oral hygiene, it's not diet. That's when you send them to the physician. Maybe there's something systemically going on. Gingival disease is modified by medications, enlargements, nutrition, then non-plaque-induced gingival diseases. You've got your viral origin, your fungal origin, and your genetic origin. So we've got specific bacterial. These are streptococci, strep mutans, gonorrhea. Okay, streptococci, gonorrhea, viral, herpes, any variety of herpes. Doesn't matter. You get the herp, it's transmissible. Fungal origin, candidiasis, which right now we're seeing in mainly HIV patients. Linear gingival erythema, histoplasmosis, and then the genetic origin, hereditary gingival fibromatosis, which is very rare. Then you've got your non-plaque induced, again, gingival manifestations of systemic conditions, allergic reactions, traumatic lesions, foreign body reactions. So you can see that there's a whole laundry list of where these gingival diseases can fall under. So which of the following drugs would be least likely to cause gingival enlargement?
D.
D. We haven't even talked about that one, have we?
No.
So the other three, yeah, so that was a good rule out. Okay, which stage of the histopathogenesis of gingivitis are T cells prevalent? Is it B cell or T cell? Which comes first?
B.
B cell comes.
So you know it's not the initial.
C.
Okay, very good. When do the first clinical signs of gingivitis show up?
Early stage.
B.
It would
Yeah.
be the initial you don't have, you've got subclinical. So B is the early, okay, early lesion. Vitamin C helps with the production of. I skimmed over that one.
Is it
D.
either A or D, I think?
Fibroblast, I think.
Oh, okay.
Fibroblasts and collagen. And chlorhexidine gluconate is a very popular oral rinse that's used in offices. We use it for a pre-procedural mouth rinse. We were irrigating with it after scaling and root planing. Patients were irrigating with it, and we're now not using it after active scaling and root planing in the office because it's been found to interfere with this fibroblast formation and collagen formation. So we're not irrigating with it. The patient can irrigate with it routinely, but right after we're done what we're doing in the office, it's best to stay away from chlorhexidine. The initial response of the gingival tissue to inflammation is?
B.
Yep, vasodilation. Let's get that increased gingival crevicular fluid. Blood vessels supplying the gingival tissue are found in the?
C.
Good job. Epithelium has no blood vessels. Okay. That's it. And I think I'm on time, aren't I? Through all of this. All right, guys, I apologize for the snafu with what's on Canvas. I'll try and get those stuff up as soon as I can, I promise. Any questions before we sign off?
I have a question. What quizzes was Hua asking about? Like they are not on Canvas. Is it for this?
Quiz is a quiz we normally do after we have lectures.
I see a quiz here, but I don't know if that's it. I went to quizzes. Isn't it that one? Chapter 5, 6, and 7?
Yeah, that's one quiz.
Yeah,
three,
but
chapter
Hua
six.
wants the PowerPoints and stuff before she takes the quiz.
Oh, okay. Got it.
I'm sorry, guys, to confuse you.
No, that's fine. That's and it's, you know, anyway, it's all good. Thank you for your patience with me. All right, go and enjoy a little bit of time before your next lecture.
Miss D, I have a question
Yeah.
about the difficulty level for the 142 patients. You said we cannot have a level, difficulty 3, correct?
We would prefer you not to because it's beyond your ability at this point.
So we're gonna have only 1 and 2?
Well, you're going to have whatever comes through the clinic. But if you've got a difficulty 3 or a difficulty 4 and you've got perio associated with it, it's going to take you so long that we'd prefer you to have easier patients. At this point, the second year students usually come trolling around clinic looking for their board patients because they need a difficulty 3 or a difficulty 4 for their boards. So you're going to be spared that this year. that so you'll get what you get. We might say, if it's, especially if it's a family member, see if you can put them off till summer.
Because I have my nanny. She doesn't have any systemic disease or anything, so probably she's like difficulty 1. But with the perio, I don't know, because she hasn't been to the
Yeah.
clinic for a while, so I don't know what I'm gonna come up with when I'm gonna bring her.
Well, we'll do the assessment and take it from there.
Okay.
Yeah, basically, we're going to let you treat whoever comes in. We might recommend that you put them off to the beginning of the summer, though.
Okay. That would be tough to find.
Or not be your first patient.
Yeah, not the first patient, no.
Yeah.
Can you recare every 3 months? If you have a difficulty 1, perio 1, can you recare every 3 months, or does that have to be 6?
It depends on why. If they have gingivitis, they could be a 1-1 with severe gingivitis or ortho or other contributory factors that they need to come in more frequently. But if they don't need it, they can't.
So if they're healthy and they're good, like the most I could bring them in is every 6 months?
Yeah, or the patient requests every 4 months. Wink, wink.
Yeah, okay. Good talk.
Thank you, Ms. D.
There's ways of getting around all of this.
Ms. D, just have a quick question that, we all have, we work with partner. So basically on the requirement, I saw that you require to have 1 pediatric and 1 medical compromise.
Yeah, no, those are just guidelines. If you don't have a pediatric this semester, it doesn't matter. You just need 4 of them before you graduate.
Oh, okay.
Yeah, so don't look at that. Don't look at, oh my God, I need a pediatric, I need a medically compromised, or I'm gonna not be able to go on. You need all of those to graduate, and 99.999% of the time, it's never been an issue. But we just don't want you getting to your very last semester and having no peds and no adolescents under your belt, or needing 4, medically compromised. You haven't had any. Medically compromised are usually, there's no problem with that. Adolescence seems to be the hardest for students to get. The teen patients. So we are even flexible with that. I just made a 25-year-old an adolescent. Asked the patient, do you mind if we consider you an adolescent? She looked young to me. There's ways of getting around it. We work with you.
Thank you.
Okay, thank you, Ms. D.
Yeah,
So both of us just have 1, is that correct? That's enough. And you said that for whole semester, we just need total about 4 to complete. Is that correct? That's what you mean?
I'm not following what you were asking.
So basically, like I said, that we have to work with partner.
Yes.
Yes, and you said that for the whole semester, so I just need 1 pediatric and 1 medical compromise.
You don't even need that if that's not who's coming through your chairs.
Okay.
You just need to have a patient in the chair all the time.
Okay.
And the rest will work out.
All right. Thank you.
So between you and your partner, hopefully the 2 of you can get together, and I've got my mom, I've got my brother, I've got my so-and-so, I've got my neighbor, I have somebody from the recare list, second year gave me, my big gave me. You'll put your thoughts together on for the 5 weeks, who do you want coming in? It's the poor person who's working solo that has to come up with their own patients. So have pity. I think, Michaela, are you the first single person?
Yes, I am.
Yeah, okay. So the single people might have to reach out going, I've used everybody I have. Does anybody have anybody extra? And share. The more we share and come together as a unit, the happier we will be when we all graduate.
Yeah, sharing is caring.
Any other questions, guys? Okay, I'm hoping to have my computer tomorrow. I'm going to be at Johns Hopkins all day. I don't know where, if I'm going to be in my car or where. It's going to be my first time going up for this. So I'm hoping to be able to get some schoolwork done while I'm waiting. So with that, I'm going to say goodbye because I've got to get ready to go to school.
Thank you.